Morning. Today I'll be talking about some other spotters. That is, you can identify something in the eye and we can see or we can look for other problems in the body as a whole or other areas. Now, I'll start now. I told you the topic is spotters in ophthalmology. Everyone knows that in ophthalmology, that is, ophthalmology help us to see. When you examine the eyes, you can see something or the status of our body or problem inside the body you can identify usually. Normally, you know what happens? We see the outside world with our beautiful eyes, but like this, we can see the outside world with our beautiful eyes. And spotters, the problems in the eye, which you can take it as a spotter, provide clinical details on what's happening at the level or inside level. Few examples I tell you. One more thing is the only place where we can see the live vessels. The retina, you can see the live vessels. That means a problem that can be seen in the vessel of a retina. You can correlate with many systemic problems. Now, first to start with, I will tell you the spotters for all the doctors, not only ophthalmology, ophthalmologist, even others also, for others also, it may help you. See now here, this is an inflammatory sign. You can see an inflammation here of the Zeiss glands called the lid margin. You can see now. Lid margin, you can see. These are all acute suppurative inflammation of the Zeiss glands, which the ducts of which open into the eyelash follicles. When there is an acute inflammation of these glands of Zeiss, glands of Zeiss, I can always, the problem is there, a recurrent problem of attacks, recurrent attacks of style, otium externum, particularly in young children. Be careful. You have to examine the patient for evidence of any refractive errors. So you're supposed to examine is the refraction, that's all. The patient may require glasses. You know why? Because of refractive error, uncorrected. The patient may have some irritation in the eye or some sensations. The fellow keeps on rubbing his eyes. Naturally, the dust from the hands can get transmitted to the eyelashes follicles and they get infected. That is what's happening. The reason for that. That's what I told you. Now, one more thing is swelling here, but it is a tarsal glands. It's called meibomian glands. These are all both Zeiss and meibomian glands or sebaceous glands. These glands, the secretions, are useful in preventing evaporation of the eye tear fluid because they produce what is called as a fatty layer or lipid layer on the top of the tear fluid. That's the most important function of these glands. Now we see a swelling here, but if you see carefully, the swelling is slightly away from the lid margin, slightly away from the lid margin. You see, compare here now, this eyelash almost near the lid margin. Can you see this? That is what is called here. It's a chronic non-suppurative inflammation of the meibomian glands, the meibomian or tarsal glands, tarsal plate glands, that is called chalazion. Then chronic non-suppurative granulomatous inflammation of the meibomian glands. Same thing holds good here also. When I find a repeated attacks of chalazions in children, I have to think about, again, I have to think about refractive errors and sometimes vitamin D deficiency also. But a middle-aged person, around 40 years old, the fellow person is getting attacks of chalazion frequently. Think he may be having a diabetes. The same problem, the recurrent attacks of chalazions in a person, elderly persons like above 60, think about carcinomas. The meibomian cell carcinomas, it's all sebaceous gland carcinomas may be there in the patient. These are suspicions of the lesion, which can guide us to investigate further. Now, you see a person is seeing like this, the distant objects. The patient is not seeing with open eyes, he is shutting his eyes or is squeezing his eyes to see. That means the problem is what? He may be having myopia. That means the fellow is, you can see near only properly, the distance not able to. You get distance vision to see them properly. The person wants to squeeze his eyes so that what is called the pinhole effect. Pinhole effect is created. What is pinhole? You know that. The rays, all the rays from the objects cannot enter your eye. Unwanted and peripheral rays are cut off. Only few rays are entering your eye, which can pass through the nodal point of the eye and falls on retina without any problems. Falls on retina. The patient can see it very nicely. That is called myopia. In myopic patients, to closing the eyes or narrowing the eyelids. Your answer is, sir, he may be having myopia. Next is one more thing. Prominent eyes. The prominent eye is there. Of course, one problem you can always think is that thyroid is different. But here, there is no upper lid retraction, everything is not there. If they are prominent eyes, again, think he may be having myopia again. He may be having myopia. So two things. Suspicion of myopia should be there in the patient when he is having a squeezing of the eyes, or that's called to shut, or prominent eyes. You know the meaning of myopia? The word myopia stands for to shut or to close. A person with myopia who is shut, he can close his eyes, narrowing his eyes. The palpable aperture can be narrowed. He can see better. That's what the meaning of the word is a common question in examinations. Narrowing of the meaning of the word myopia is to shut or to close. If now another patient in the lid margin, I can see a molluscum. Molluscum, you can see now is a pox virus inflammations. It can be multiple also. It can occur in children. It can occur in any age. But most important is what? Molluscum, if I see in young adult, beware of immune deficiency states, AIDS. That means when I find a molluscum in young adult around 20-25 years of age, be careful. The fellow may be having AIDS. One more thing, everyone knows this bite or spot is there, is a normal affair. Vitamin A deficiency is there. So naturally, bite or spot when you see in children, be careful. Again, vitamin A, vitamin deficiency, vitamin A, you have to at least give treatment. The fellow may become normal. That means the problem cannot be, cannot increase. The fellow may be having starting with night blindness, that is different. But the serious problems of keratomalacia, involvement of cornea, they all can produce blindness in the patient. That is why find what bite or spot in young children, be careful, give vitamin A treatment. And one more thing, classical I can tell you, see now this is called xerosis. Can you see a xerosis of the dryness, the conjunctiva here, the dryness of conjunctiva. You can see here, I will tell you one thing. See now, can you see black spots? Here's a black spot is here, black spots is here. That is called, whenever I see particularly in our country, in children, particularly the girls, small girls, if you find a small black spots in the conjunctiva, multiple black spots, think it may be what? Addition of, kajal, or that kajal or surma, that has been normalized enough, normal affair. That means what children are having applied, the kajal. This kajal, the black kajal can get adhered to the conjunctiva if it is dry. That means what? If it is wet, it cannot. It can get washed off. That's why whenever you find a black spots in the conjunctiva of a small girl, that too in our country, think about the problem of vitamin A deficiency. He may be having what? Conjunctival cirrhosis, dryness. That means what? If you give a treatment for vitamin A, the patient become normal. That's all. Deficiency. If you give it the vitamin A, patient become normal. That is called as classical. Seeing a black spots in the conjunctiva of a young girl, suspect vitamin deficiency because of kajal. That is called, because of kajal application, you can see the black spots. Now the wind, that's called imtiaz sign. Imtiaz sign is a common exam question again for postgraduates. What is imtiaz sign? Your answer is, sir, I can see black spots in the conjunctiva of a young small girl. If I see, I have to rule out vitamin A deficiency because the kajal that is applied to the eye can get adhered to your conjunctiva because of dryness. Now, what happens now? Prompt identification of these problems like recurrent stye, recurrent lesions, all these things, narrowing of alveolar aperture. So naturally, imtiaz sign, all these things, when you give a timely treatment, can save the problem of the patient. If suppose myopia is not treated, he will become ambulopic, that is partial loss of vision with that, that's all. He will not, when a myopia is not treated, he will not develop in outside activities. He will not develop any interest. That means what, he is forced to see near only. That is why he will not develop any interest in outside world. This is what black spots. Of course, I have drawn this picture. This is the way the black spot will be there. The kajal applications can lead on to imtiaz sign. Next, when I see some discharges there from the eyes, redness, discharge, bilateral, redness, discharge from the patient, bilateral problem, it usually conjunctivitis. What conjunctivitis? It has to be because of watery discharge. Because of watery discharge, it is viral, adenovirus usually. Whereas if you see redness, all these things, unilateral, think about herpes. Think about herpes, simplex virus problems. It's a common thing. So unilateral, slight redness, watering, problem, photophobia is there. Think about herpes. Whereas bilateral, watery discharge, redness, think about adenoviral infections. Suppose the same discharge is not watery. It has got some mucus associated with a pus, mucopurulent. You have to think about bacteria. Bacteria, never forget. These are the classical questions. Understand now? This is what, based on discharge, you can tell the most probable etiology. Now, one more thing. Patient has come to you, sir, I'm having unexplained, something not able to explain now. Sir, I'm having itching. Itching sensation in the lid margin. Never forget to examine under the slit lamp. Magnified views. You will get these things. These are all called louse. Louse infestations of lid margins or the eyelashes. This we call it as theriasis, PHT, theriasis palpebrarum. Theriasis palpebrarum. Inflammation of the lid margin, blepharitis, because of louse infestations. This you can treat. Once you treat, you can always treat the patient. But the problem is what now? We have to treat the entire family. They may be having these problems. And moreover, bed sheets, whatever things, pillow covers, everything have to be treated. Otherwise, this person will get keep on recurrent attacks of these problems only. And eyelashes turn inside. You know, here the eyelashes turn inside. Can you see an eyelashes turn inside? This is called trichiasis. Trichiasis is what now? Inward turning of the eyelash. Even a single eyelash is turned inside. Even a single eyelash is turned inside. Think about trachoma. Trachomas, chlamydia trachomatis, infections with the trachoma. And what happens now if the trachea is there? If you're not treating, the trichiasis will rub the cornea, will be rubbing the cornea. Epithelium can get damaged. Epithelium can get damaged. And once the epithelium has come out, naturally the secondary infections can easily affect the cornea, resulting in corneal ulcers. That means what? Once the corneal ulcer is occurring, they will develop inflammations. Once it heals, you can have what? Opacities. Opacities are the reasons for your visual loss in these patients. Corneal opacities are the reasons for your visual loss in this patient. Corneal opacities are the reasons for your visual loss in these patients of trachoma. See now one more thing. You see now here, the lid margin have got some vesicles. Similarly, the tip of the nose also got some vesicles. When I examine the eye, you see some corneal involvement. You see now some iris problems. I can see some atrophic changes here. And I see hyphema also here. That means what? When I see a vesicle on the nose or a lid, always think about vesicle that to unilateral distributions. It is an herpes zoster problem which can involve your cornea, resulting in keratitis. The same patient can have uveitis or iritis also. Because of that, he can develop hyphema. Never forget this. And he can develop atrophic, it's all ischemic vasculitis. So ischemic changes, vasculitis, they can result in atrophic changes in the iris also. This iris atrophy. Always remember, iris atrophy can also, it's a segment called sectoral iris atrophy. Can occur in herpes zoster. But when you see a vesicle on the tip of the nose, I told you herpes zoster, think about what? The corneal involvement. You know the why? The tip of the nose is supplied by external nasal nerve, which is a continuation of anterior ethmoidal nerve. Anterior ethmoidal nerve continues as external nasal nerve supply the side of the face, side of the nose, side of the nose and tip of the nose. When this antiethmoidal, what is this antiethmoidal nerve? It's a branch of nasociliary nerve. Branch of nasociliary nerve, which is a branch of ophthalmic, you know the ophthalmic. The same branch, another branch of ophthalmic only, that is called long ciliary nerve. Long ciliary nerve supplies your cornea, conjunctiva, taking sensations. That is why when you find a vesicle in the tip of the nose, suspect a problem in the cornea also, because of the nerve that is supplying the tip of the nose, a branch of the same nerve. It's a branch of the same nerve, which also supplies your cornea. That's why the problem is there. This is called Hutchinson's sign rule. Now, specifically, ophthalmologist, when you see something in the fundus or something in the eye, suspect some other problem in the systemic problem. Also, you suspect. Now we see herpes simplex. I already told you. Now, when you see this, the herpes simplex, now we have got dendritic ulcer. Maybe that one of the problems, herpes simplex, they can develop punctate keratitis, which can lead on to dendritic ulcers, or which can lead on to geographical ulcers or amoeboid ulcers. So many things are there. That's why this herpes simplex virus, when you find that herpes simplex problems, see the cornea, he's having dendritic ulcer. Imagine now dendritic ulcer. In this case, dendritic ulcer is where now here, the central part. Can you see now? The dendritic ulcer like these branches. These branches are having a bulb-like expansions in the branches. Bulb-like expansions in the dendritic ulcer branches is pathognomonic of herpes simplex. Pathognomonic herpes simplex virus. The classical, no other condition have. These bulb-like expansions. These are called bulbs or knobs. These are called bulbs or knobs. Knobs-like expansions in the branches ends. But one more important point, what now? The dendritic ulcer. Now you can see now dendritic ulcer center. Now the same another person is having ulcer-like figure in the periphery. But it's also herpes simplex. Imagine now, it's also herpes simplex. Now the problem is what? A normal person having normal immune status will develop a herpes simplex dendritic center. Whereas dendritic ulcer near the peripheral part of cornea, think about AIDS. Think about AIDS. That means what? Peripheral location of the dendritic ulcer, we have to rule out AIDS. Because in central part, the problem is there. You know this. Always remember herpes simplex in a normal person. Herpes simplex, dendritic ulcer in the peripheral location, think about AIDS. One more. See, now it's also a sign for ophthalmologists. When I see an engorged vessel like this, in the conjunctival area, these are called sentinel signs. Sentinel sign means when I find an engorged vessel in the sclera of this area, think about the problem somewhere inside the eye, a melanoma, maybe ciliary body tumors. There are so many ciliary body tumors. So there, at least think, when you have a sentinel sign, think he's having a melanoma or he's having a ciliary body tumor. That's enough. That's enough for you. That means what? If you find a sentinel sign, think about a ciliary body problem, or inside the eye, some tumor is there. Corkscrew vessels. See, now we have got this called medusa head appearance. Medusa head appearance. Corkscrew-like vessels. Corkscrew-like vessels. Medusa head appearance. Medusa head appearance. Medusa head appearance. That means I have to rule out keratoconus fistula. I have to rule out keratoconus fistula. Never forget this. When I find a corkscrew vessels, that two medusa head appearance, he may be having proptosis also, or maybe he may be giving a history of some head injuries, or he may be having or hearing some noises in the head. So think about he's having fistula. And squint. See, now here the child has got the right eye is deviated inwards. It's called convergent squint. Here also is called also convergent squint. That means what? This convergent squint in a child, be careful. Examine the eye properly. Inside the eye, you can have retinoblastoma. You know why? When the retinoblastoma, if it involves the central macula, the vision is getting affected. The child cannot fix it. So naturally, it will take a resting position. For the child is convergence. Adult is divergence. Agreed. But in child, usually a blind eye will go for convergence in a child. You know why? Is also an exam question. Your answer is, sir, the middle rectus is very powerful. Is very powerful in young children. That is why the eye will be deviated inwards. So that means what? When you find a squint, be careful. That means there's a tumor inside the eye. You can see now, this is all the optic disc. See, the tumor is here. That is involving the macular area. That's involving the macular area. And one more, iris. You see now, you have got iris pearls. Small pearl-like deposits, pearls. When I find an iris pearl in a patient, it's a pathognomonic sign of leprosy. These are all lepra pearls. These are all called lepra pearls. You know, ask me, is a diagnosis? What leprosy? I have to rule out. What type of leprosy? Lepromatous leprosy. Lepromatous leprosy. That means what? His immune system is gone. Immune system is definitely damaged. Now we have got, when I cut this question for examinations, when I cut this lepra pearl and see what's there, what will be there, your answer is, sir, I can see lepromatous bacilli arranged in cigar bundle, CIGAR. That's the arrangement of the lepra bacilli, arranged in a cigar bundle. Now, there are some nodules like this, we can have yellowish nodules, here like this, nodules and all. These nodules, whenever I see, that is called Lish nodules. When I find Lish nodule in the iris in a child, always remember, the child may be having neurofibromatosis. Von Recklinghausen's disease. Then you have to suspect what neurofibromatosis. The chance is there for the child to get a problem. The child can have a glaucoma also. Unilateral glaucomas can develop. Unilateral increase in intraocular pressure. That's the idea. When you find Lish nodules, it's a pathognomonic sign of neurofibromatosis. There are some pathognomonic signs. So far, I told you what now? Dendritic ulcer with a branch, with having bulbs, pathognomonic herpes simplex. Then one more I told you, lepra pearls in the iris, pathognomonic of leprosy. And Lish nodules is a pathognomonic of neurofibromatosis. Now, when you see the cataract, the patient has got cataract. I think I told something about these problems. when I was talking about the side effects of drugs. But here, whenever you see a posterior capsular cataract, posterior subcapsular, not capsular, posterior subcapsular, posterior cortical cataract, always see the fundus. When you see the fundus, in the fundus, the macula, I've got a bullseye. Bullseye maculopathy. That means what? Think about chloroquine. That's all. The patient might have consumed chloroquine. So always remember, when you find a posterior cortical cataract or a posterior subcapsular cataract, think about chloroquine toxicities. Now, when I see here Christmas tree-like cataract, Christmas tree cataract, like maybe in the posterior cortical area only, usually think about myotonic dystrophy. That means Christmas tree cataract in your eye. Christmas tree in your eye. That myotonic dystrophy. Myotonic dystrophy. But a common exam question here, what now for postgraduates of ophthalmology? Myotonic dystrophy is what? Orthomal dominant. Here, one peculiar feature you are supposed in the exams. Sir, this patient is having 50s, 55 years. He has developed a cataract. But now his generations, his son, daughter, and all may develop cataract at the age of 45, 50. Their sons and all develop. So we got generations. The incidence or the starting point for starting the cataract is early. Each generations will develop early cataracts. At least this is called phenomenon of antedating. Phenomenon of antedating or anticipation. So I anticipate what? Suppose a myotonic dystrophy patient is there, his son is there. You have to follow him, you have to examine him for early development of cataract. This is one. Myotonic dystrophy is one of the causes for early onset cataracts. Other things, if you're asked, no examination, other causes for early onset, your answer is, sir, diabetes. Your answer is, sir, atopic dermatitis. Never forget. Then neurofibromatosis type 2. Neurofibromatosis type 2 can have early onset cataract. If you are the exams, early onset cataract, you write all these 4 conditions. Never forget to write about myotonic dystrophy also. And examine the disc and all, optic disc. See now, I've shown this picture before itself. It's a venous pulse. This is called spontaneous venous pulse. It corresponds to the diastolic period of cardiac cycle. This may be absent. Sometimes you cannot elicit also in a case of papilledema, raised intracranial pressure. That means what? The venous pulse, when get a case of this, you see the optic disc. See the pulsation. If it is absent, you can think about that. That's all. That means always the venous pulsation absent means suspect some problem may be there inside the brain. Some problem, but need not be always. It may be absent in 20% of normal. It may be absent in 20% of normal fellows also. But suspect increase in intracranial pressure. Suspicion is the must. Next is what now? See, the papilledema is there. At the same time, I can have a fan. It's called macular fan-like appearance. This is called macular fan. And you see now macular star. See now the difference? Macular star's fan is between the optic disc and the macula, whereas star is around the macula. When I see the fan, when I see the macular fan-like appearance, it's what now? It's nothing but the foldings of internal limiting membrane. Folds of the internal limiting membrane. Or maybe, of course, incomplete. It's only hard X-rays. But basically it's what? When you see a macular fan appearance, think you are dealing with a case of space-occupying lesions, increased intracranial pressure. And when you have a macular star, along with the disc problem and all, along with our disc edema, think about you're dealing with a malignant hypertension. Yeah. My one advice, whenever a patient has come to you with a papilledema, don't suddenly jump to order a costly investigations. First to take his BP, blood pressure. It's a must. If you're not taking blood pressure, if you're going to present the case without taking blood pressure in the exams, you're finished. No excuse. That's why whenever you encounter a papilledema patient, never forget to take the BP of the blood pressure of the patient. It's a must. See now artery pulsations. I told you, artery pulsation is there. You can see now artery is pulsating in the optic disc. You can see now it start. You can see this. Now we see artery pulsations. When you have artery pulsations are seen, when the blood pressure is 120 by 80, think the intraocular pressure will be more than diastolic pressure of CRA. I already told you once. Remember now, because suppose I'm having 120 by 80, general BP, there is a blood pressure in the brachial artery. 2/3 of 120 is 80, 2/3. 80 is the systolic pressure of CRA. 120 by 80 is the diastolic pressure of systemic. Half is a 40. So 40 is the diastolic pressure of CRA. 2/3 of systolic and half of diastolic is a BP of your CRA. Now imagine now my intraocular pressure is more than 40. That means more than diastolic pressure. Think. Arterial pulsation will be there. That means what? When I see arterial pulsations, think about maybe a case of glaucoma, maybe a case of raised intraocular pressure. Sometimes in disc, I can see a colobomatous defects, colobomas. You know what is coloboma? The defective embryonic fissure closure. The defective embryonic fissure closure. You know, embryonic fissure starts in 6th week of gestation and closes by 8th week of gestation. If it is not closing properly, the coloboma can occur anywhere, maybe in the iris, maybe in the choroid, maybe in the optic disc, everywhere the coloboma may be there. But when I see a coloboma of the optic disc, think about the classical exam question again, the charge associations. What is charge? Coloboma, anomalies in the heart, atresia choana, then retardation, mental retardations, genitourinary problems, ear anomalies. These called charge associations. Charge associations. When I see a coloboma, think about, examine his heart man at least, examine his ear man, and see the mental caliber of the patient, and see any genitourinary problem is there or not. Like this. ENT examinations, heart examinations, all these things are a must. When I see a coloboma of the optic disc, this is what a spotter for us. It's a spotter for systemic problems in the body. And now the disc is giving us clue. Morning glory appearance. It's called morning glory. So, like, what is the difference between coloboma? Coloboma, you see now your defect is there. But in morning glory, the disc is completely filled inside. A glial tissue is there. You can see a glial tissue. Glial tissue is here. And you see the vessels are coming out like a spokes. It's a morning glory appearance, usually unilateral. Coloboma can be unilateral, bilateral, anything. But morning glory, usually unilateral. Optic disc. When I find a morning glory, the problem to be ruled out is what? In the patient as a whole. Now we see. I have to look for the midline deformities, cleft palate, cleft lip. That's why, when a patient is brought to you with a cleft lip or cleft palate, think you have to examine the fundus. The patient may be having morning glory syndrome inside. Or you may be having transparency basal encephalocele. They can have midline deformities, problems in the corpus callosum, these areas. That means what? I have to rule out a morning glory syndrome is there. Think about cleft lip, cleft palate, and spinal encephalocele or basal encephalocele. One more that may be there. We can have an atresia of the vessels, like a intracardiac arteries and all. That means what? They can have, once an atresia is there, they can develop collaterals. They can develop collaterals which can be demonstrated in angiogram. In angiogram, that is called a puff of smoke. It's called puff of smokes. That is called puff of smoke appearance. Puff of smoke. That is called moya moya. That's called as moya moya. Moya moya means when there is an atrophy or atresia of the vessels supplying the brain area, when I take angiogram, I can see collaterals like a puff of smoke, puff, P-U-F-F, puff of smoke, smoke. And the terminology given for this moya moya is, and of course, Japanese term, moya moya. This is also an exam question again. You see the beauty now. Patient, imagine now the patient has been brought to you with a cleft palate, start examining his fundus, examine his brain, and you can see some problem maybe in the atresia or that means you're going to find out the patient. Now here, eye is acting like, something, give us a clue regarding the problem in the patient as a whole. Regarding the problems in the patient. Now we see, this is called myelin sheath around the optic disc. Myelin sheath is there. But the myelin sheath, normally, around the axons of the optic nerve, myelin sheath is there. They will stop at lamina cribrosa behind the eyeball in the sclera. Lamina means a pores in the sclera to which the axons are going. That multiple, we have got what is called myelin sheath. This normally stops at lamina, but very rarely they can enter into the eye. Around there is, please remember, this is not going to produce much problem for the patient except for some field defects. The vision may not be affected in this patient because it's around the disc only. The vision may not be affected, but he can have what? He can develop some field defects like enlargement of blind spot. The blind spot size increase, that's all. But the importance what? When suppose I see a person having myelin sheath now, I make a note. Now the same person has come to me or is coming to me after a year with a visual loss. I have to rule out multiple sclerosis, demyelination problems, demyelinating problem. That is a reason for your optic nerve problems. So that's the importance of noting down this myelin sheath in the person. Retina problems, you know, these we got hard X-rays, cotton spots, so many things are there. See the venous dilatations, like this venous dilatations, then we can have cotton, there's some hard X-rays and ring pattern, succinate pattern, you know, all these things, you know, hard X-rays. Okay, these are all hard X-rays, and you can see a soft X-ray here. These things what? We can give a clue. So venous dilatation along with hard X-rays, along with the succinate pattern. Be careful. It's a diabetic patient. Similarly, can in the arterial narrowing here, the arterial narrowing is here, and the AV crossing changes are there. AV compression of the veins and all. When I find AV crossing like this, we have got so many names are there. Gun sign, Saulu sign. So many signs are there for this hypertension. When you find this arterial venous crossing changes, think you are dealing with a case of hypertension in the patient. It's a spotter for us. One more thing is now, can you see here, class carefully, the blood column is broken. Can you see a blood column is broken here? This called is cattle truck appearance. Cattle truck. That means the blood column is broken and moves in a jerky manner. That means what? He is having a retinal artery occlusion. Central artery occlusion is there. But the problem is what now? When I find central artery occlusion, what the problem do you have to rule it systemically? Be careful. The embolus might be coming from your heart, or maybe coming from your bifurcation of common carotid arteries. The embolus may be coming from there to block your artery, at the level of lamina cribrosa. That's why when you find a CR occlusion, never forget to rule out. You have to examine the cardiovascular system thoroughly. That's the importance of a spotter for CR occlusions. Pigmentosa, these called pigments, usually it's a genetic problem. They will experience or they will report the night blindness cases. Later on, they will develop what these are called bony corpuscle. These are all called bony corpuscle-like pigments. Bony corpuscle-like pigments. That means when I see a retinitis pigmentosa patient, think about the fellow may be having endocrine problems like obesity, hypogenitalism, or the fellow may be having deafness. That is called Usher syndrome, USHER. Deafness, dumbness, and dumbness and retinitis pigmentosa. That means what? Deafness, dumbness, Usher syndromes. And they can have ataxias. And they can have Refsum disease. You might have heard about Refsum disease. One important point, when I find retinitis pigmentosa, see the eye movements. And all. You may be having ophthalmoplegias. At the same time, you can have ptosis, the drooping of the eyelid, and examine his heart. Heart is what? We can have heart blocks. That is called, you must have heard about this, Kearns-Sayre, K-E-R-E-A-R-N-S, Kearns-Sayre syndromes. That is what? A patient got RP. When I find RP, examine the other movements of eye, everything. Examine the heart, cardiovascular system. You have to examine, or at least refer him to the cardiologist, so that like at least you can prevent the major problems in future. That is the advantage of spotter of RP, patient's importance. And it's here a white-centered hemorrhage. That is called Ross spots. Ross spots are what? White-centered hemorrhage. What is that? It's nothing but accumulation of leukocytes. Leukocytes in the center of the hemorrhage. When I find this, most important problem to be ruled out is never forget subacute bacterial endocarditis. Subacute bacterial endocarditis. There are so many causes which can produce. There are so many causes which can produce your raw spots. But the most important problem you have to rule out is what? Subacute bacterial endocarditis. Okay, people also, even to diagnose death, man, even if you want to diagnose a patient is no more, you are seeing the pupil only. You are seeing the pupil and you see the pupil dilated, no reaction. You then only confirm. Okay, that's why even to diagnose death, your pupil is important. Now the question is what an interesting question. In rigor mortis, the patient is, suppose morning 8 o'clock is, the patient is dead. After 6 or 7 hours, you can say rigor mortis. You know, all the muscles are all getting contracted, you know that. But in the eye, at the time of death, the pupil is dilated, no reactions. But in rigor mortis, the pupil is constricted. Never forget this. You know the reason. Rigor mortis can affect all the muscles, both voluntary and involuntary muscles. Both voluntary and involuntary muscles are affected. Now in the iris, the constrictor pupillae is very powerful compared to dilator. That is why constrictor is very strong, means it can constrict easily. That's why in rigor mortis, the pupil is constricted. Never forget. It's a common exam question again. Now we can see now light, the pupil is not working. In light, no pupil is not working. When you ask him to converge, see now the pupil is constricting. It's called, for light, it is not working. For near working, it's called, you might have heard about Argyll-Robertson pupil. You know, accommodation reflex present like the Argyll-Robertson pupil. You know that in tertiary syphilis. But now in Argyll-Robertson pupil, normally, the pupil will appear small only. Here the pupil normally appears larger. So it cannot be Argyll-Robertson. It cannot be Argyll-Robertson pupil. It cannot be. Because syphilis cannot be, this patient cannot be a syphilis patient. But what's the problem you have to rule out? Never forget, your light reflex pathway for the pupil, is in the dorsal portion of midbrain. Whereas the near reflex, the accommodation pathway is in ventral portion of midbrain. That's why when you have a dorsal midbrain problems, a pressure coming from top, like a pineal body tumors, they can compress your midbrain dorsally. The light reflex may be absent. For near, it may be working. It's called light-day dissociation. In this patient, actually, we have detected what now? He was having some problems in the brain, above the midbrain area. That's called dorsal midbrain syndromes. Similarly, you got right eye pupil is working, left eye is dilating. Again, swinging flashlight, right eye is working, left eye is dilating. That means what? Left eye optic nerve problem is that. That's all basically. You know that. That means maybe optic neuritis. Left side optic neuritis. Maybe that. The contraction problem is there. This is called Marcus gun pupil. It's called Marcus gun pupil. Marcus gun. That is relative RAPD. Marcus gun pupil or RAPD. RAPD means relative afferent pupillary defect. Okay. Now the problem is what now? One important point here. The pupil in the left side is afferent problem is there. But never forget, the nasal retina is more important for all these reactions. Because the nasal retina is more. You know the nasal retina is crossing in the chiasma entirely. Nasal retina is crossing in chiasma. And then come to my opposite tract. Never forget, when you have a left eye shows Marcus gun pupil, problem may be in the optic nerve. Again, same side optic nerve. But if you want to see the tract onwards, optic tract onwards, the problem is involving opposite side tract. That is what the exam question again. In optic tract lesions, the pupil will show relative afferent defect in the opposite side. This is what exam question. And one more here, one important point for the postgraduates. Now we see, suppose I'm having right optic tract problem. Right optic tract problem is there. I know the right optic, I've got the left nasal fibers. Nasal retina is there. That means the left eye will show RAPD. That is the Marcus gun pupil is there. But at the same time, the pupil of the left eye is slightly larger. The pupil of the left eye is slightly larger compared to right eye. In right optic tract lesions, that right tract has got nasal retina of the left side. So the left eye pupil will be slightly larger. Okay, that is called as, again, for is a classical question, that is called Behr pupil. Behr, B-E-H-R, Behr pupil. Behr's pupil. Behr pupil means in optic tract lesions, you can get this. Now, sometimes, Horner syndrome is there in a child. Sympathetic palsy. The pupil is small, ptosis is there. That is Horner syndrome. The sympathetic pathway is long. Now, you see, the pathway is starting from hypothalamus down to some, we got spinal cord, no? C81 level, again comes out. They're passing by ganglions, sympathetic ganglions. But that means when you see in a child, Horner syndrome in one side, think about neuroblastomas involving the sympathetic ganglions. That is what impart the spotter for the eye and relation to body. Understand? Infected rule, I told you. Neuroblastomas involving your sympathetic ganglions. Suppose I'm having nystagmus. Like this, you got this is called optocanal nystagmus. This is the optocanal. That means one movement is slow, one movement is fast. Coming back is fast. This is called optocanal nystagmus. This was the train, no normal occurring in a train. You can see now. One is moving, again come back. Moving, come back. What's happening here? This is called optocanal nystagmus. This is a drum. It's a physiological phenomena. This phenomenon, the optocanal nystagmus, is a physiological phenomena. I can see, rotate this drum and find out. The beauty is what? When I rotate the drum, the patient has a pursuit. You have to pursue a stripe. Now stripe is disappearing. He has to come back and take the next coming stripe. So that means I'm moving the stripe. I'm moving the drum like this. Now he's following a stripe. Then the stripe has gone out. So he has to come back. That is what's happening in the nystagmus. This pursuit movement, it has to take place. It has to pass via the instructions via parietal lobe. When the parietal lobe problem is there, this pursuit cannot be there. This movement cannot be elicited. That's why this nystagmus, a sign now, is this nystagmus. If it is absent, if you are not able to elicit it by rotating the drum, think about the parietal lobe lesions in the patient. Basically, you are supposed to know this. Parietal lobe lesions. Now, how do you know nystagmus? There is a voluntary movements. No, you got involuntary movements. Involuntary movements are there. How do you know it's congenital or acquired? One important question. In congenital nystagmus, outside world remains stationary. Whereas in acquired nystagmus, outside world will move. The environment is moving for him. That's called oscillopsia. So when oscillopsia is there, it's acquired. When the patient is not experiencing much of oscillopsia, think about congenital nystagmus. That's all. This is what hope you have understood something in the patient. Spotters in the eye, which can give us a clue so that you can examine the patient as a whole. Thank you very much. And thank you very much for this opportunity now. Hope you have understood something about the spotters. I'm definitely to help you in your examinations. Thank you very much.